I'm going to set the scene with a small presentation on biomechanics of patellofemoral stability. Now, if you look at the problem of recurrent patellar instability, we know that if any patient sustain a second dislocation of patella, the redislocation can be as high as 71% in certain series. What it means is that the condition that affects this young population can be quite significantly disabling. And what is important is that it's not just one particular thing that's going wrong. There are a number of things that could be contributing to this instability, and they all interplay the role into it. And therefore, it's really important to understand the biomechanics. What are the factors that in normal situation helps to stabilize patella, and what are the things that can go wrong that can contribute to instability? So what I'm not going to talk about in terms of biomechanics today is the contact pressure and the stresses. I'm just going to concentrate on the stability aspect of the patellofemoral joint. So there are three elements that needs to be understood when we look at the biomechanics of PFJ stability. One is the soft tissue. Second is a PFJ articulation itself, including the trochlear morphology and the position of the patella, and more generalized forces acting on the patellofemoral joint, whether it is lateralized, neutral, or more on the medial side. So these are the three main elements that we need to understand the stability. So let's look at the soft tissue. We all know the soft tissue on the medial side, the dynamic stability provided by VMO is one of the most important things. Doesn't matter whether you are looking at non-operative intervention, whether it is a post-op rehab, it contributes significantly, and almost every patellofemoral pathology, doesn't matter whether it is instability or not, it plays significant role. But more important in terms of patella instability or dislocation is the medial static structures. And recently, this has been kind of recognized as a medial ligament complex. And if you look at that, the picture on your right-hand side, in the recent past, there are a lot of structures which are identified and thought to contribute to patellar stability. And some of them are medial patellofemoral ligament, or medial patellar meniscal ligament, or medial quadriceps tendon femoral ligament. And the one that we are most aware of and the most significant one is medial patellofemoral ligament. And I think it is important to understand that medial patellofemoral ligament is important close to extension, maybe up to 20 to 30 degrees of flexion. That is where most stabilizing effect of this ligament is. And as I said, MPFL is probably one of the most important structure because it contributes to up to 60% of the forces that resist the lateral patellar displacement. So it's really important one. Now, from clinic application, from the practical application point of view, it's important to understand that your MPFL is a check-in, i.e., it is stopping lateral displacement of the patella. It is not the structure that you try and reconstruct to pull the patella. So that's important thing to consider both in terms of biomechanics and surgical treatment. The other thing is that the change in the length of the MPFL is isometric, i.e., it does not change the length except for first 10-20 degree where it is slightly longer, but otherwise it is same length throughout range of movement. And the last thing about MPFL is just to know the stiffness or ultimate load to failure, we must understand that it has got, it's a low stiffness structure, and therefore any other soft tissue structure that we consider in terms of treatment, we need to make sure that it is not significantly different than the native structure. Now, if you look at the lateral side, there is lateral retinacular structure. Now, it is made up of contribution from number of other deep fascia on the lateral side. And some authors do suggest that there is structure called LPFL, that is lateral patellofemoral ligament. Clinically, what is important is that structure tight or not? And that is quantified with the tightness. And although we can see that on MRI scan, the most important thing is a clinical assessment of that tightness. And the way you can look at it is that, can you really lift that patella from tilted position? And if you can't, it is tight, but otherwise it is not. So it's important to assess that because that may contribute to certain extent lateral tightness or laterally directed forces. So if you look at the second portion, which is important, second aspect of PFJ stability is PFJ articulation. And there are two important things in PFJ articulation. Now, PFJ articulation provides bony stability, and that starts from around 20 to 30 degree flexion onward. Two things we need to consider: trochlear morphology. And if you look at this arthroscopic picture, you can see that normal trochlea is nicely concave shape with medial and lateral trochlea providing that mediolateral stability. But equally important, the patella has to be at a particular height. It has to engage into that normally shaped trochlea. So patella height is equally important. So these are the two important structures that provide stability as the patella will engage beyond 20 degree of flexion. Now, any deviation from this normal morphology, whether it is shallow trochlea, flat trochlea, or significantly convex trochlea, that can affect the biomechanics of the stability. And the one thing that I'll draw your attention to is the significantly convex or the severe form of trochlear dysplasia. Doesn't matter how well you correct the other biomechanical abnormality. That's something that significantly affects the biomechanics, and that needs to be addressed. And that is the importance of understanding how abnormal that trochlear morphology is. And I'm sure this is going to be discussed later on in the presentation of the radiology. But I think I cannot not highlight that do not complicate things. There are different classifications available. This was the classification that was developed and published, I think, 2 or 3 years ago. And it simplifies the whole issue, where you just look at the trochlear morphology and say that it is mild abnormality, which is a shallow trochlea. Is it moderate abnormality or moderate trochlear dysplasia, which is a flat, and then severe, which is complex. But this probably will be discussed later on in the presentation and discussion. Coming to the patella height, the question is, how do you quantify when it is biomechanically significantly abnormal? And if you look at this zoom diagram, you can see that there is hardly any overlap. What it means is that patella is not engaging in that normal trochlea to gain that stability that it should get at 20 degree of flexion. Now, we published this around 12 years ago, and it has got a lot of historical measurement methods described into that. And I wouldn't go into detail, but I'll just mention a couple of things because biomechanical it is relevant. One is a Catton-Brisson method of measuring patella height. The one that I think makes biomechanical sense and that really explains to you whether the patella has got a problem in terms of the height is the patellotrochlear index. And basically what it shows is that is patella engaged into the trochlear groove, and is there overlap of the patella and trochlear cartilage? That is what you want to look at. And I think we looked at the literature, what is the evidence, and we did our own study in normal healthy population. And without going into too much detail, I would say that if you see that the overlap of this trochlea and the patella cartilage is less than 3, 1/3 of the patellar articular cartilage, then you need to start thinking, could it be contributing to patellar instability? Now, the last thing that we need to consider, we probably need to go away from the patellofemoral joint. There are other factors a little bit away from the patellofemoral joint or close to patellofemoral joint, which could be forcing lateralizing forces on the patellofemoral joint, and that can be a contributing factor on top of the any other underlying pathology. So what are the lateralizing forces? The main lateralizing force is dictated by how well central or lateralized your tibio tubercle position is. And again, this will be discussed later on, but the way we look at the lateralized position of tibio tubercle is by looking at TTTG, or clinically by J-shape tracking of patella. What you need to understand with TTTG is that TTTG indicates path taken by extensor mechanism, i.e. it's a comparison of the point on the femur, that is trochlear groove, and another point on tibia, that is tibio tubercle. So even though tibio tubercle can be normal, if a femoral groove is on the medial side, that TTTG will be abnormal. And that is why TTPCL was introduced. And again, this will be discussed later on in the radiology section. Now, as I said, there are forces away from the patellofemoral joint that can contribute to instability as well. And one of the commoner example is valgus malalignment, and something like that. There is no doubt that it is going to contribute to a certain extent to patellofemoral instability. The other thing which is less well understood, but we have started to recognize is axial malalignment, i.e. rotational or torsional malalignment. in general, it causes more of the lateral pain, but sometimes it could be abnormality that would contribute to the instability. And I think there are two specific torsional abnormalities that we need to be aware of. One is femoral anteversion. And when you have got femoral anteversion, essentially your trochlea is moving more medial in relation to the patella, and it is relatively causing lateralized forces. Another factor that can affect the lateralizing forces or can cause lateralizing forces is external tibial torsion. And essentially with external tibial torsion, your tibial tuberosity is more lateralized, and therefore any force, any active extension will have slight lateralizing forces. And very rarely, patient will have combination of external tibial torsion and femoral anteversion. And this could be a challenging problem, both for the patient as well as for treating physician, treating clinician. Last but not the least, we must not forget dynamic alignment. And what I mean by dynamic alignment is that even though your structures, both at the patellofemoral joint and slightly distant, are completely normal, if you've got weakness of the proximal muscles, that is your abductors and external rotator, it can put your limb into relative valgus and internal rotation position. And that can exert lateralizing forces as well. So what it means is that if you've got underlying pathology that can cause patellar instability, and on top of that, if you've got this problem, then it is going to contribute to instability. So I think this is the last slide. In summary, what we need to understand is that there are a number of reasons why patient may have recurrent instability, whether it is MPFL insufficiency, whether it is too high patella, which is not engaging in the trochlea, or even if it is trying to engage, we don't have that medial lateral stability because of dysplasia. Could be lateralized tubal tubercle, could be torsional abnormality or valgus alignment, and last but not the least, proximal muscle weakness. And it is important to understand that if one abnormality is of mild variety, if there are 2 or 3 other abnormality, that will exaggerate the problem related to the first one. And similarly, when we treat this, when you treat one abnormality, it can help with the other abnormality as well. And I think I'm going to stop there. Thank you very much.